through. We probably won't get through them all, but that's okay. So originally, Dr. Carney told me to give a lecture about uveitis. Uveitis is a very small proportion of what I see in my rheumatology clinic. And I get, of course, I manage this as a team with ophthalmology. So we're not really going to just talk about uveitis today. We're going to talk about JIA too, because that's the most common reason we see folks for uveitis in a rheumatology clinic. And really, as far as, high yield stuff that you guys need to know about, I would say JIA is way up here. You need to know about uveitis and association with JIA and other reasons folks can get uveitis, but I think JIA is probably the more high yield topic to go over today. Okay, so we're going to learn about the symptoms and causes of uveitis and understand a little bit then about JIA. So what is arthritis versus arthralgia? We're going to talk about all of the subtypes of JIA if we have time. Formulate some differential diagnoses for some cases of patients with uveitis and understand just the basics of JIA treatment. All right, I'm going to start by talking about uveitis a little bit. So what is uveitis? Inflammation of the uvea. So that's the middle portion of the eye. So anything kind of in this part. Can you see me when I'm pointing at my slides or no? No? Okay. Let me see if I have a little pointer. Oh, look, a laser pointer. That's cool. Okay. So the anterior portion of the uvea is really kind of the iris, the ciliary body, and then the posterior portion of the uvea is like the choroid going back. So most of this pink part. And again, I by no means am an ophthalmologist. So this is my my best understanding of all this. Anterior uveitis, you see leukocytes in the anterior chamber. So up here in this part. You see the leukocytes up here from the inflammation in your iris. So this is what is also called iritis, if you see that in folks' notes from ophthalmology. And then if you have inflammation in the ciliary body as well, that's what they call iridocyclitis. Posterior uveitis, you have evidence of chorioretinal inflammation, so going back into this part as well. Panuveitis then is inflammation of all of it. So it's important to differentiate anterior versus posterior versus panuveitis because that helps you build your differential, especially within the autoimmune, autoinflammatory diseases that cause uveitis. They tend to have different patterns of eye involvement. So knowing what part of the eye is involved will help you when you're thinking about what has caused uveitis. Excuse me. Okay, so what does cause uveitis? Infection, for sure, and we'll go through some of those. Then my autoimmune and inflammatory diseases, rarely drug reactions. There are a few other rare eye-limited diseases that can cause uveitis. And then you always have to have a good old idiopathic category for the ones that we're not sure what has caused it. So as far as infectious causes, there are a lot. A few that I will point out, and ones that, so the way that this often happens is a kid will somehow get to ophthalmology and they will say, you have uveitis. Usually the ophthalmologist or their primary care doctor or I will order tests to rule out infection if there aren't other signs and symptoms of a systemic inflammatory syndrome. So the ones that I will test for when I see a patient for the first time for uveitis, if they haven't had it done already, would be cat scratch. If they have risk factors for Lyme, I will send Lyme. I will look for CMV and EBV. Occasionally herpes, though herpes eye involvement is the most common eye involvement is not uveitis. Sometimes we'll send histo, and we will send toxocara and toxoplasmosis studies as well. So those are kind of the most common ones that we'll look for. Oh, and TB is the other main one that I skipped over. We will do a quant gold or a skin test for TB. So then moving on to more rheumatologic causes of uveitis, JIA is the big one and the most common one that we see, and that includes the ankylosing spondylitis, HLA-B27 associated arthritides. Behçet's, sarcoidosis, IBD can all cause uveitis, Kawasaki's disease, lupus, a rare syndrome called Voigt-Koyanagi-Harada syndrome, and then tubulointerstitial nephritis and uveitis syndrome, which I've seen a couple times too. All right, so the symptoms really depend on, going back, what caused the eye inflammation and what part of the eye is affected. So some types of uveitis are painful and red, other types are not. So most importantly, in JIA, they get chronic anterior uveitis that is usually painless and asymptomatic until they have developed damage. So that's why my JIA patients, I stress the importance of going for their frequent ophthalmology exams to get screened for evidence of inflammation so that we can detect it early and treat it before it causes eye damage. Other types are more acute and will cause pain and blurry vision and redness, sometimes photophobia. So the problem with uveitis is if it goes untreated, can cause some significant vision limiting complications. So band keratopathy, posterior synechii, cataracts, glaucoma, and macular edema can all happen because of uveitis, and I'm going to show you some examples of these. So this picture, you can see these little kind of cloudy specks in the front eye are little deposits of white blood cells. So I look at my patients' eyes in clinic, my JIA patients, when they come in, and really I'm mainly looking at the front part of their eye. I'm not going through and trying to see their optic discs. I really mostly care about the front of their eye. So rarely I will pick up on these little smudgy parts. Of course, if it goes on longer, this is a cataract, which is no good. And then this is the other main thing I look for, which is posterior synechii. So this is actually scarring of the iris. So these parts that are coming down are parts of the iris that have gotten tacked down by scar tissue. So it's not able to expand and contract normally because those parts are kind of bound down and stuck. So you get a really irregular appearance of the pupil. So I look for this as well for signs of uveitis. All right, that's uveitis in a nutshell. Any questions before we move on to some JIA? We're going to talk a little bit more about JIA and who's at risk for uveitis and what types as part of kind of the JIA discussion. Anybody? Bueller? Okay. All right. Arthritis versus arthralgia. We went over this a little bit when I gave y'all a lecture about causes of joint pain like 9 months ago. But to refresh your memory, kind of the definition of arthritis, you have to have swelling, or if you don't have swelling, You have limitation of range of motion accompanied by pain, tenderness, or warmth. So the easy way I say this always when residents come hang out with me in clinic is, do they have painful, limited range of motion? Because that's kind of what you have to have arthritis. Arthralgia is just joint pain. You don't have swelling, you don't have limited motion. It's just pain. So that kind of, when you see a patient, is the first thing you need to decide. Does this patient have signs of arthritis with swelling or painful limited range of motion, or do they just have joint pain? So there are lots of causes of arthritis as well. Osteoarthritis, of course, which kids don't usually get. You have to think about your infectious causes of arthritis and post-infectious, like, toxic synovitis in the hip, post-strep reactive arthritis. Rarely malignancy can cause arthritis. And then, of course, all of the other autoimmune causes that I see in rheum clinic. All right. So JIA is the most common rheumatic disease of childhood. It's what I see patients for most often. Previously, we called it JRA, as in juvenile rheumatoid arthritis. We do not call it that anymore. Please call it JIA, not JRA. We don't know exactly what causes it, but like all autoimmune diseases, there are HLA associations that seem to likely predispose patients. They have evidence of immune dysregulation, and then there's likely some kind of environmental or infectious trigger that causes the inflammation to rev up. All right. So back in 1967, we first kind of defined JIA, and these things are still true. You have to have arthritis for 6 weeks or longer in any one joint. You have to have an age of onset less than 16, and it's a diagnosis of exclusion. So you need to think about those infectious, post-infectious causes, mechanical causes, malignancy, all of those things before you say this is definitely JIA. And it's really an umbrella term because, as you know, there are several different subtypes that present with different patterns, have different prognosis, but they all share the common feature that you have arthritis somewhere for 6 weeks or longer in a kid less than 16 years old. All right, so let's talk a little bit about how we classify them. This is kind of so the original old school way, when it was called JRA, we had pauci-articular, which we now call oligo-articular, polyarticular, and systemic. So pauci is 4 joints or less, poly is 5 joints or more, and then systemic is a category of its own that also has rash and fever. So why did we change the name? Kids far more often do not have a positive rheumatoid factor. So it's not rheumatoid arthritis. It is heterogeneous. So the idiopathic kind of goes back to we don't know what causes it, and there are different types. It is definitely unique as far as the prognosis and the associations that it has with uveitis and for systemic JIA macrophage activation syndrome compared to rheumatoid arthritis in adults. All right. So when kids come in and I say you have arthritis, these are the things they have usually complained about. Joint swelling. In little kids especially, parents will say, I just started noticing that they were limping. They'll often complain of difficulty with writing or difficulty doing their buttons, joint stiffness, lots of morning stiffness. But you will note that the chief complaint is usually not isolated pain. Usually they have some change in their functional capacity in addition to pain. And especially in little kids, they may not have complained of pain at all. It may be more that they're really fussy in the morning and they want to be held. But parents will not always necessarily have identified like my kid's knee hurts. It's more of I noticed that it was swelling or I noticed that they were limping, but less often just pain. So there are lots of myths that I hear about JIA, or when I'm talking to community pediatricians on the phone, they'll say, well, I figured it wasn't JIA because X, Y, and Z. So these are things that I want you guys to know are not necessarily true of JIA. So SED rate can be normal in some cases. They can not complain of pain, like I talked about. She has no fever or rash. Some subtypes don't have fever or rash. The ANA is negative. Lots of patients have a negative ANA with JIA. Rheumatoid factor is negative. Like we talked about, that's why we changed the name. Most of them have a negative rheumatoid factor. There was trauma at the beginning. I see lots of red herring stories about she fell down at the playground, and so we blamed it on that for the first, couple weeks, especially in toddlers. What do toddlers do all day long? They fall down. So that is often the first time a parent will have noticed it when they have some kind of trauma that leads them to look at it, or there's almost always some fall recently that they can blame. Joints are not red. Red joints make me think more infection than JIA. So kids with JIA, their joints usually are not red. And only one joint is involved. Well, oligoarticular JIA very often is only one joint. So do not let any of these things lead you to believe that it's not JIA if there are other reasons pointing to it being JIA. All right, so what labs do we do? Rheumatoid factor, negative in 95% of children with arthritis. It can also be positive in many conditions, especially after a viral infection. So I see lots of rheumatology panels ordered in primary care to rule out arthritis, but a negative rheumatoid factor does not rule it out. And I see a fair number of kids for a positive rheumatoid factor who have no actual arthritis on exam. ANA is positive in 95% of lupus patients and in 80% of oligoarticular JIA. But as you guys know, and I harp on every time I talk to you, it can be positive for lots of other reasons in addition to just normal kids can have a positive ANA. So many positive ANA tests are in just healthy people, and this does not rule it out. The main reason that we get it in JIA patients is to risk stratify for uveitis. So kids with oligoarticular JIA and polyarticular JIA with a positive ANA are much more at risk for developing uveitis, and we actually have them get screened more frequently than kids with a negative ANA. All right, SED rate. SED rate is a good test. It indicates inflammation in many conditions. So again, it's not specific for JIA, but some patients with arthritis, especially those oligoarticular arthritis patients who only have one affected joint, they may always have a normal SED rate. So don't use that to rule this out either. X-rays are, I think it's important to get X-rays, but they are normal in most patients with arthritis for at least a year. And some patients will always have a normal X-ray, especially if I'm doing a good job in controlling their arthritis well. All right. So I basically just told you none of these labs are great, right, for saying this is definitely JIA or definitely not JIA. So it really comes down to being a good diagnostician. You have to get a detailed history, a comprehensive physical exam. The lab tests can help, but they're non-specific, and it's really all about looking at the pattern. So any one piece of information is going to be meaningless out of context. You have to look at the whole picture. Okay, so we have evolved to classify this a little bit differently now. And so now we're going to go through kind of the way that we talk about JIA nowadays and the different subtypes that we see in Rheum Clinic. So expanding a little bit on that kind of chart that we looked at initially, we call it JIA now. There's still kind of these three big categories that help me think about JIA as far as oligoarticular. Do they have more joints involved, or do they have systemic symptoms? In oligoarticular patients, I will say, okay, is this a little kid like toddler age or older? Because the little kids are more likely to just be the regular oligoarticular JIA category. If they present initially in the first 6 months with 4 or less joints, but develop more joints later, they may become an extended oligoarticular JIA patient. The older patients who present with just a few joints, I think more about, are you actually the enthesitis related arthritis category, which we'll talk about more. Patients who are polyarticular, 5 or more joints, I say, okay, are you rheumatoid factor negative or positive? You can have a polyarticular JIA with a positive rheumatoid factor that does act more like adult rheumatoid arthritis. These are more often kind of teen or preteen age kids that have severe disease that can be challenging to treat. When their rheumatoid factor is negative, they can still have polyarthritis. This tends to be more toddler age kids with polyarthritis, but can be older kids too. And I also think some about, are you a psoriatic patient? Which again goes back to the pattern. Do they also have psoriasis or a family history of psoriasis? Do they have DIP involvement or dactylitis? And then of course the systemic category is over here all by itself. So these are patients who are also having daily spiking fevers, rash, can have hepatosplenomegaly, and we worry about this sometimes even before they present with the arthritis. They can have the other category, the other symptoms first. And y'all stop me at any point if you have questions. I know it's hard in Zoom world, but jump right in if you need to. All right, so now we're going to learn about the subtypes a little bit by going through some cases. So case number 1, this is Madison. She's a healthy 2-year-old white female. She's fussy in the morning and she wants to be carried. Later on in the day, she's fine unless she takes a nap or goes on a long car ride. Otherwise, she's perfectly healthy. On exam, she has a big right knee, which has a limited range of motion. And her labs are really pretty non-impressive. Her CBC is normal, SED rate's a smidge high at 25. She does have a positive ANA at a kind of moderate titer, not super high, and her rheumatoid factor is negative. This is what she looks like on exam. Look how big her knee is. So looking at her, these are the things that point out to me, that jump out to me. She's a toddler. She's otherwise totally healthy. She has 1 joint affected and a positive ANA. Does anyone want to take a stab at what subtype this is?
Oligo.
Oligo, great job. So polyarticular is the name they used to call it. Oligoarticular is what we say now. I don't know why that changed. This is what we see in little toddlers, more girls than boys, tends to be more in Caucasian individuals. And this is kind of the classic textbook picture that you see. Half of these kids only have 1 joint, and it tends to be knees. Next most common is ankles. Occasionally I'll see an elbow, but really mostly knees and ankles. 20% will go on to develop chronic uveitis, and this is the group that's at highest risk for that, especially the younger females with a positive ANA. So you have to have 1 to 4 joints for at least 6 weeks, the stiffness in the morning. These are the kids, like I said, that will often come in with some story of mild trauma that's not actually related. And then of course you have to have decreased range of motion on exam, positive ANA, and then the slit lamp exam will become abnormal in 20%. So These things are not usually oligoarticular JIA. If it's red or if it's like painful out of proportion to their exam, hips are not usually oligo JIA. If they have any fevers or super high sed rates, that would make me scratch my head a little bit. If they're absolutely refusing to bear weight, or if they have any small joint involvement, I would think, is this actually going to be one of the other categories? So we talked about the uveitis. It's pretty common actually to have it in both eyes at presentation. The later complications we talked about. The bad news bears is when 10% of them have it preceding their arthritis and half of them have it at presentation. And the thing that's bad about that is they're more likely to have damage because they don't even know that it's there. So this was the case, a little boy I saw recently and just started treating. He had had probably joint inflammation for a year or so based on the history. And when I looked at his eyes, he already had synechia eye. And parents noticed that he had been kind of squinting a lot lately, so already probably has some significant eye damage. When they have uveitis, that's an indicator to us to go ahead and treat them with systemic therapies like methotrexate or often TNF inhibitors. Enbrel doesn't work as well for uveitis, so we'll go to Humira, Remicade, things like that. If they don't have uveitis, sometimes we'll start with some NSAIDs, but I will move very quickly to doing an intra-articular steroid injection. If they are resistant to being treated with just injections or high risk because they have uveitis, we will treat them with the same meds that we use for polyarthritis, methotrexate, TNF inhibitors, really first line. Studies have shown that treating with intra-articular steroids really works well as first line treatment to prevent leg length discrepancy. These kids, so when I talk to parents about kind of long-term prognosis, this is what they always want to know. Like, what does this mean for them going down the road? So half of them, and this was a study from 2000, so we've come a long way even since then in our treatments, but in 6 years follow-up of a 200 patient cohort, half of them ended up having polyarticular disease, so going on to develop more joints. About a third of them had significant joint erosions. About a third of this cohort had uveitis, but also about a third of them went into remission. So I usually tell parents about a third of the time this will go away completely. A third of the time they'll have a waxing and waning course where they might have periods of time where they need medicine and periods of time where they don't. And another third will have more kind of severe disease that requires long-standing medications. Unfortunately, we don't have great ways to predict which category kids will fall in. All right. Questions about oligos before we move on? Okie dokie. So case number 2, James is a healthy 11-year-old boy who has had knee pain and ankle swelling for about a year. It's stiff in the morning and he's starting to have a difficulty with sports where he has to run. His mom is part Native American. On exam, he has point tenderness over his tibial tuberosity on one side and at his Achilles insertion. His left ankle is swollen with mildly decreased range of motion. His CBC is significant for normal-ish hemoglobin. His SED rate's high, and he's ANA and rheumatoid factor negative. So thinking about the overall picture and pattern here, he is a boy and kind of more school age, has Native American background, and has these features that I would say are consistent with enthesitis, meaning inflammation at the insertion of tendons at his patellar tendon and his Achilles tendon, but then also seems to have arthritis in his ankle. So this is enthesitis related arthritis. I think this is the most poorly named category because they don't always have enthesitis. They can just have arthritis, but many of them do also have enthesitis as well. In adults, this is the category that we call spondyloarthropathy, and they can go on to develop ankylosing spondylitis in their spine. It is older kids, is way more actually males than females. It tends to be prominent in Native American population, but I see it plenty in other ethnicities as well. So the typical patient is an older boy with, they have more lower extremity symptoms, knees, ankles, and feet. Usually they present as oligoarticular. You can have tarsal involvement in the foot, which can be challenging to treat, and then the enthesitis like we talked about. They are also at risk for developing uveitis, but it's more acute. So they'll have a red, painful eye. You'll be more kind of aware that something's going on. As far as labs, this is a patient I would check an HLA-B27, and they're positive over 80% of the time. They also tend to get sacroiliac involvement with time. Is another feature, another joint we often see involved. I'm just going to skip this for the sake of time. This is a study from 2005 just showing the effectiveness of TNF agents in treating juvenile spondyloarthropathy patients. So each line represents a patient, and this is the number of active joints that they have, and this is the number of active entheses. And so you can see by 6 weeks on a TNF inhibitor, these kids are really doing much better. All right. So we've talked about the oligoarticular category and early versus late onset. So now let's move on and talk about some of the others. All right. So Charlotte is a 13-year-old African-American female who jammed her left third and fourth fingers playing basketball 2 weeks ago. She went to the ER and got x-rays that were negative, but they've stayed swollen since then. And on exam, she actually has 12 swollen joints, primarily small joints, and it's bilateral and symmetrical. Her CBC is significant for mild anemia. She has a SED rate of 62. Her rheumatoid factor is positive, and her ANA is positive. So thinking about the overall picture and pattern here, she has, she's a 13-year-old African-American girl. She has lots of joints involved. They're small joints, and she's rheumatoid factor positive. So this is a rheumatoid factor positive polyarthritis. This tends to be more older kids, like I talked about, tends to be more girls, is more common in Hispanic and Black females. This is more, this is angry arthritis. So it tends to be more destructive, harder to treat, can have more just, fatigue, malaise, because they are more systemically inflamed. They have small joint involvement, lots of PIPs, MCPs involved. Rarely you can get subcutaneous rheumatoid nodules, and they really can have any joint involved. So going back through her labs, you can see anemia, thrombocytosis as a feature of just their kind of overall inflamed state. Their SED rate's going to be high. Their ANA can be positive. So it's not uncommon for someone to be worried about lupus in these patients as well, which should probably be at least considered, making sure they don't have other signs of things like lupus. Rheumatoid factor is positive, and they're more likely to have erosions on their joint films sooner than later, unfortunately. So it's kind of hard to tell, but hopefully you can appreciate that there's a rheumatoid nodule right here. The lateral is easier to see it. I do not see these often. Here is an unfortunate x-ray that shows some erosions. You can see here in this PIP, this one's losing some joint space. Here you can see some, there's a lot of periarticular osteopenia. All of these carpal bones look really crowded and can become fused over time if the inflammation is not controlled. So this is some bad stuff going on. So these are way less common to go into remission, unfortunately, and you need to really treat them early aggressively. We're flying through, but stop me if you have questions. Okay. Next week, and do I go all the way till 9? Someone nod. Okay. 2-year-old blonde white female noted to be toeing in with her feet, pigeon toe, at her 18-month well check. She went to an orthopedist. They braced her for 6 months, but she didn't get better. Ortho saw her back and said, "This doesn't seem right. Let's have you go to rheumatology clinic." When we examined her, she had 27 swollen and limited joints, and labs were normal. So it's a little bitty one with lots and lots and lots and lots of joints with normal labs. This is more likely to be a rheumatoid factor negative poly. So again, this is more toddler age, girls more than boys, very similar to the oligoarticular JIA patients, more in Caucasian females. There is a question whether this is really just a spectrum of the same disease that we see in oligoarticular patients. They have uveitis a little less common, but can have a positive ANA and be at risk for uveitis as well. Some of the things that can be really challenging are when they have TMJ involvement, which can cause micrognathia and really be, facially disfiguring, which I'll show y'all some pictures of. You can get C-spine involvement. Really, sometimes these kids will come in and it seems like every joint is involved. It's really sad. But they tend to get better with treatment more than the RF positive patients. So occasionally they can have anemia and thrombocytosis. Sometimes their SED rate is high, more than the oligo category. Sometimes their ANA is positive. Their joint films are also often normal, and their rheumatoid factor is negative. If they are having other symptoms, beware. Or if their joints are extremely painful, tarsal involvement or enthesitis would make you think more about enthesitis-related arthritis. And if they have isolated DIP involvement or dactylitis, you should think about psoriatic arthritis. The things that we worry about, like I talked about, are the growth disturbances. So TMJ, you can get leg length discrepancy. So early on in an inflamed joint, you will actually have a longer limb where the involved joint is because of the increased blood flow with the inflammation. But then you can get premature closure of the epiphyses, and the joints can make that limb smaller in the long run. So if someone asks you if involved limbs are longer or shorter in JIA, you can say both. It's a trick question. In general, they also have decreased bone mass, more in their cortical bones than trabecular bones. This is more accentuated when they have active arthritis going through puberty, and again, correlates with the severity and activity of disease. Sometimes we have to use a little prednisone in these patients, which has all of its own challenges, as y'all know. So this is a polyarticular JIA patient. I want you to notice this arm is longer than this arm, and she has a tiny jaw. So here she is close up, and here she is from the side. So it's really retrognathia and micrognathia, set back and small. Occasionally, these kids will need surgery to correct this. So here she is after she's had it pulled out by a plastic surgeon, which really made a big difference. Okay, How do we treat polyarthritis? Methotrexate is our first line, and then we quickly go to TNF blockers and abatacept, which is Orencia. Occasionally, we'll also use tocilizumab, which is Actemra. Rituximab works well, especially in the rheumatoid factor positive patients. Excitingly, now we're using more tofacitinib, which is Xeljanz. The good thing about that is it's a pill and not a shot or an infusion. So my patients get really excited when I bring up that option. We'll sometimes do targeted joint injections in places that are really bothering folks. And then there is a limited role for steroids when folks come in really hot, arthritis everywhere, until these meds kick in, because they often take several weeks before they really get to maximum effect. So this is a study of patients on Enbrel, showing how quickly they decrease the number of active joints and joints with loss of motion after just a few months on a TNF blocker. Okay, moving on. Any questions? All right. I can't see the chat, so I don't know if people are popping up anything in there, or if there even is one. Nope. Okay, good. All right, case 5. Kristen is a 2-year-old blue-eyed blonde who developed swelling of her left ankle and her right 4th digit. Her PCP took some x-rays and said, maybe this is an allergic reaction that's making your finger swell. A month later, she also developed right wrist swelling. On exam, she has a sausage digit. She has swelling in her wrist and ankle with decreased range of motion. Her CBC is normal and her SED rate is 25. Her ANA is 1 to 160 and her HLA-B27 is positive. And she also has now developed chronic uveitis. So really the features here that clue me in are this sausage digit or dactylitis, 2 joints, and now she has some bad chronic arthritis, uveitis. So this would be psoriatic arthritis. Can be both in toddler age and in older kids, more girls than boys, tends to be more in Caucasians. The dactylitis is often a clue here. The chronic uveitis can be bad. They can get the psoriasis later. I also look for nail pitting as a clue. So here are some examples of dactylitis. This toe's big, this toe's big, this toe's big. That is a mighty swollen finger. Here's more of kind of the DIP involvement you can see in this finger. And this is a really great example of nail pitting. You can see kind of these little dimples in the nail. Okay, so JIA, you can have oligo, polysystemic, we talked about, all of these folks. So that leaves us one left, right? Which is systemic. Yay! Systemic is different. So remember that. That's one of my main takeaways always when I give this lecture is systemic is a whole world of its own. So here's a representative case. 9-month-old white female developed a pale pink macular rash all over her body and a daily spiking fever. Her hands and feet were swollen, but she did not have conjunctivitis or oral changes. She was diagnosed with Kawasaki's disease and treated with IVIG, had minimal response, continued to have high fever and swollen hands and feet for the next 2 months. So daily fever, pink rash, getting swollen joints. She's pale and fussy. She has a macular salmon colored rash on her trunk, and she's got arthritis all over the place. On her labs, she has leukocytosis with a neutrophilic predominance. Her platelets are super high. She has a really high SED rate. Her albumin is low, and she's ANA and rheumatoid factor negative. So this is systemic JIA. In adults, they call this Still's disease. It can happen at any age. It can happen in boys and girls. Does tend to be a little more common in Caucasian patients, though both of the new systemics I've seen since I got here have been African American girls. Daily fever, pale pink rash that tends to happen more when the fever actually happens. So this is not always the pattern at the very beginning, which can make this challenging. So sometimes it takes time for them to really develop the characteristic pattern of fever at night, the rash comes with the fever, and the arthritis can happen later as well. These patients can start to get lymphadenopathy. They can have pericarditis. The patient who was just in the hospital that we diagnosed with this had a little pericarditis. They can have hepatosplenomegaly. The rash, I think I'll show you pictures of, and then they get arthritis. Whoopsie daisy. Oh, I think this is showing some big lymph nodes. Pericarditis, big heart. Here are some classic pictures of the rash. So can be mistaken for urticaria at the beginning, but one feature that might tip you off is Kebnerization, meaning if you scratch somewhere, then the rash will pop up. So that's what you can see here in these kind of linear areas are places they've scratched and then the rash comes up. So you have to have daily fever. The definition says that this has to be there for 6 weeks or longer. If it's characteristic, I don't make these kids suffer with fever for 6 weeks. We will start treatment. These kids look more sick than other categories of JIA. Their labs are significant. Their ferritin is often high. When it's super, super high, you have to say to yourself, are there other things that make me worried about macrophage activation syndrome? Because that is the biggest cause of morbidity and mortality in these patients. Uveitis is rare in these patients, so that if they have uveitis, it's probably not systemic and they probably have something else going on. And if they have a normal CBC or a lymphocyte predominance, that would also be not in line with systemic JIA as well. So here's another patient. This is Lauren. She was diagnosed at the age of 18 months with systemic. She's had some flares and remissions. At the age of 4, she had a presumed viral infection, started having more high fevers. She got a little loopy and delirious and had some dark urine. Her labs are significant for a white count of 7, a hemoglobin of 10. Her platelets are a little low, and her SED rate's not impressively high. So what does this make y'all worried about? I just talked about it. MAS. So here you see macrophages that are eating up other cells, which is no bueno. So MAS can be associated with viral infections, flares of systemic JIA, changes in meds, or just can happen for no good reason. You have to distinguish it from just a flare of the systemic JIA, and it's really important that you recognize this early and treat it early because it can be truly life-threatening. So evaluate for infection. Historically, bone marrow has been done to confirm diagnosis. We don't usually do that anymore. They need high-dose steroids. Occasionally, we'll need to use cyclosporin. I am not going to go through all of this right now in interest of time, but if you want to come nerd out and talk about all of the little mediators of MAS, come by my office anytime. So how do we treat systemic JIA? It, compared to everything else we've talked about today, which is more in the autoimmune disease category, T and B lymphocyte mediated, systemic JIA is an autoinflammatory disease, meaning it's more NK cell macrophage neutrophil mediated. And really what we need to target are the inflammatory cytokines. So IL-1 and IL-6 are the cytokines we target. Historically, all we had was NSAIDs, lots of steroids. Sometimes we'd try methotrexate. None of these work great. So IL-1 does a lot of things, as does IL-6, to kind of rev up the inflammation in these patients. So we treat them with IL-1 and IL-6 inhibitors. Anakinra is usually what we start with because it works fast. So this is 13 systemic JIA patients from 6 to 24 months, showing their clinical response with both fever and arthritis on anakinra. Not sure what happened with that guy. And showing also that their white count came down, their hemoglobin went up, their platelets came down, and their sed rate came down. So anakinra, we also have rilonacept and canakinumab, which are other IL-1 inhibitors. We'll use IL-6 blockade with tocilizumab. We really need limited steroids in these patients unless there's signs of macrophage activation syndrome. One thing to just be aware of is we have new concerns about a really terrible interstitial lung disease in these patients. We're still trying to work out if it is caused by severe disease or by actually a drug reaction from IL-1 and IL-6 inhibitors, which has made kind of the way we treat this and think about this challenging at times. So for all of the subtypes of JIA, it is really important that they get physical therapy and occupational therapy. They will develop limb contractures and weakness that we really need to directly work on with therapies. Parents always ask me about nutrition changes. There are no specific diet recommendations I make. Omega fatty acids are the only kind of proven thing to have some anti-inflammatory effect. But in general, I tell them shop around the outside of the grocery store, try to eat more whole foods than processed foods. And then there's just the element of psychosocial support. The Arthritis Foundation is really great. I try to get parents plugged in there to really, you know, connect with other parents and other kids who have JIA and to get education. So here's our chart of all the arthritis we went through. We talked about uveitis a little bit, and there's 5 minutes for questions. Sorry, that was really fast. Anybody?
Quick question about like our African American friends. It's just really hard to appreciate a rash in them. So would you have an earlier threshold to call rheumatology in our kiddos with a rash with high fever and we don't have a good explanation?
Yeah, for sure. Both of the African American patients with systemic JIA that we've treated recently have had like a more urticarial looking rash. So that might be one clue. But I agree. And that's one thing. The American College of Rheumatology has started to address the problem of historically the images that we've used for publications and teaching are of Caucasian patients and not patients with darker skin. So they're really trying to get out more pictures of what these things look like in darker skin to help us know better how to identify it.
So in systemic JIA, with the rash, does it come right away with the fever, or is it maybe the rash develops a few days later, or how does that work?
Yeah, the pattern is not always there initially. Sometimes the fever can come first, sometimes the rash can come first. But really with time, it usually falls into the pattern of at least the rash is more prominent when you have the fever. And the fever tends to be more one spike at night. Sometimes it's two spikes, a morning fever and a night fever, but not everybody plays by the rules and follows the textbook. But that's what's most common. is kind of with time, it will fall into the pattern of nightly fever. The rash comes with the fever.
And can that rash be anywhere on the body?
Yeah, it can be all over.
What are the best ways to distinguish RF positive polyarticular JIA and rheumatoid arthritis?
They're really the same disease. We just call it JIA when they're 16 and under. So we treat them very similarly. You know, they have the same kind of risk factor of having long-standing disease that we need to treat aggressively. So it's the same disease. We just call it a different name when they're under 16 to make it as confusing as possible.
Thank you.
Mhm.
I have a question too. So I guess generally like understanding like the concepts of like JIA versus, you know, we talk about it as a autoinflammatory disease process versus an autoimmune disease process like you were talking about. I know like the cytokines are all the inflammatory process, but I know that it's really complex and it can also be considered part of the immune you know, system too. But I guess kind of narrowing that down, I suppose you just categorize that because it's all based off of the ILLs or ILs. Is that right? Or basically the cytokines all depend on the cytokine activation system. Is that why you characterize it like that?
You mean like making the differentiation between autoimmune and autoinflammatory?
Yes.
Yeah, and it really has to do too with the primary cells involved. So when they do, when you look at, you know, synovial tissue in patients with oligoarticular JIA, there's more T cells there and B cells involved than systemic patients who have, you know, features of, you know, macrophage activation and K cell dysfunction. So in addition to the cytokines, it's also the kind of primary immune cells that are involved in the process. Is that what you're asking?
Yes, like
Okay.
I guess the distinction between the autoimmune would be, I always thought it was more of like antibody dependent.
Yeah, so you know, it's still the T and B cells are more of what we consider, you know, the adaptive immune system. So even if we can't identify specific, you know, a named antibody that is causing JIA, it's still that more adaptive immune process rather than the innate immune process of macrophages, neutrophils, and K cells. Does that make sense?
Yes, thank you.
All right, anybody else? Okie dokie. Thanks, you guys. Come hang out in Rheum Clinic. You're doing a good job. I know you've been crazy busy. I appreciate you all.
Thank you.
Thanks, Dr. Dingle.
Thank you, guys.